again, and the topic is, as mentioned by the president, it's a I think it's a very important topic, right? Before it starts, I also like to introduce myself here in detail. Yes, I was in Shanghai University Medical College and school teaching convenience and clinical work in the dental hospital for 25 years. I took the position as chairman of both departments for 20 years. Right? And then I also was working in the University of Sydney, taking the professorship there for 5 years, working with Professor Ali for quite a long time in Sydney. Right? And now I'm the professor and the supervisor, PhD supervisor in Wuhan University. At the same time, I'm also just in the university, right? In Sydney. I trained the Australian local orthodontic specialists for 3 years of coursework program, right? And I went back to my home institution, and then I'm now a PhD supervisor in Wuhan University, China. At the same time, I'm also president or director of a very huge dental hospital in Shanghai. We call it Shanghai Taikon dental hospital. It's very huge. It's a very big one. We have 80 dental chairs. We have huge premises. And the location is very good. It's the very center of the Shanghai CBD. Right? So if you guys have any chance to come to Shanghai, I would be pleased to see you guys taking a visit to my hospital, and if possible, to go to Wuhan University. Right? All right. So we have 2 parts more because we have only half an hour for the class 2 topic. And then class 3 topic will be the next session. That's 1.5 again, okay? So first of all, we just go directly to the problem which has been endured us for a long time, okay? Habitually, statement between 3 that application is facial complexity. Facial complexity is especially in the area of the map area is very intrusive, but it was similar between China and Vietnam in terms of that category of facial appearance. Okay? All right. Import map vision is very common phenomenon. I think you guys also encounter lots of cases with very deep white, very deep white figure. The white is so thin that low incisors cannot be visible, right? Very deep over jet, very deep over white. Sometimes we have very deep curved speed, right? One of the scenarios. And we also have such a scenario that we have a very deep white. Again, the low incisors are all covered by its upper incisors, right? Indicating that over white is very deep. Right? And then we also have such a situation where the rejuvenation of that front is such that it just disguises the increased overshare. Actually, overshare is also really big. Right? So there's 3 scenarios where we have all deep white, up front position quite different. The first one, upfront is very proclined. The second one is very straight, and the third one is reclined. Right? Just have an initial impression because deep white, they have, in terms of the position of upper front teeth, they are quite different. Right? Alright, so into the deep white solution further, if we look into further, what we can find, there are 4 traits in common. Okay, they have 3 or 4 characteristics in common that they are increased overjet, deep overbite and deep curve speed together with class 2 molar relationship. These four triggers taking place together. Right? Okay. So if we take a look at these situations further, we could find that the increased overjet, increased overbite, and increased the curve speed together with class 2 molar relationship. There's no exception that these three phenomena will take place at the same time. Okay? Yes. So we call it because they have an increased overjet, overbite, curve speed. So we can call it deep overjet, deep overbite, deep curve speed. So the simplicity of that term is 3-depth malfusion. Just keep in mind or memorize that simple word, 3-depth malfusion. Alright? 3-depth malfusion is. So now taking a look into these phenomena further, 3-depth malfusion is always coupled with facial complexity, facial protrusion. Right? The facial looks a little protrusive, especially in the white area. So in Oriental population, facial complexity is very common. Right? Patients do not feel very happy with their facial appearance. Alright, so now the association between the malocclusion, which is 3-depth malocclusion, and facial appearance are very, very closely linked together. Right? I have to say, if they have malocclusion, 3-depth malocclusion, your clinic, definitely the facial appearance will be like is concave rather than straight or convex. It's convex, not concave. Right? So they are associated. It is a strong association or conjunction between facial appearance and the malocclusion. In terms of the 3-depth malocclusion, the facial appearance is not either not straight or not concave. It has to be very convex. Okay? So the phenomenon is very interesting. Take a look at your patient. You have a review of the patients. Right? If your patients having a malocclusion of 3-depth, the facial appearance is not very good. Okay. Now, so we call this particular malocclusion 3-depth malocclusion with facial complexity. They are always linked together. Okay? 3-depth malocclusion with facial complexity. That's the term, special term describing that phenomenon. Okay. So how should we treat this particular malocclusion, 3-depth malocclusion? Traditionally and conventionally, we always think about the teeth or the dentition themselves, trying to have a camouflage, additional camouflage to meet or to reduce the increased overjet, to open the deeper bite, or even to flatten deep curve speed. But it doesn't work very well. Traditionally, we have either having a discolorization, buccal discolorization, huge millimeters, like a 5 millimeters of discolorization, to trying to reduce overjet, to convert the molar relationship, or even open the deep over wide. It doesn't work very well. Okay? It's also the buccal or molar discolorization is one of the most important forms of dentitional camouflage. Right? Teeth to teeth. We are struggling with the teeth, trying to have a correction of the discoordination between the teeth. That doesn't work very well. Right? The second way is more radical, taking teeth out. Okay? It's reasonably detectable everywhere. Teeth extraction is one of the most important treatment modality for orthodontics. I have to say extraction is a radical form of dentitional camouflage. Right? But with 3-depth malocclusion, if extraction doesn't work very well either. Right? So we may not take that extraction result unless we have to do the extraction. The most suitable situation is severe clouding with class 1 relationship. Okay? For the class 2 model relationship with 3 depth malfunction, be careful. Alright, extraction will be always the last resort unless we have to do so. Right? Okay. Now the third way is to send the patient to the surgical theatre for the surgical correction between upper and the lower jaw discrepancy. Right? For 3 depth malfusion, no matter how severe the discoordination between upper and lower dentition and upper and lower jaw, the surgical intervention is not the best choice. Sometimes not at all, right? So these 3 conditional, so the treatment modality may not be correct if you have like a 3 depth malfusion patients in your hand. Okay. So the following are the way that we are trying to do, right? To correct the 3 depth malfusion using a special clear device or special clear technology. We call it mandibular repositioning technology. Okay, take a look. The case where we have a quite proclined upper front teeth, 3 depth again, very severe. The patient was actually 45 years of age, traveling around China seeking this treatment. There's no exception. She was told that there's no way except for she was for the surgical intervention. Otherwise, there's no way that the malfusion could be corrected, right? But we did not do that. We have a special advice, right? And then we finished that case in such a way that the patient or doctor saw her, felt very surprised, okay? That it worked in that way. Right? Take a look at another case. The case is where the upper front teeth very straight, 3 depth malfusion. Again, severity of the 3 depth is very, very marked. And the patient was traveling around China again, being told that there's only one way that correction of malfusion is possible, surgery. Right? But we did not do that. We have a special advice again, and we finalized that case with not only the beautiful model relationship conversion from class 2 to class 1, but also a correction of what? Of a 3 depth problem. This is another case, example case, where we have a 3 depth that upper front teeth are declined, and also with such a category of malfusion, the surgical indication much getting stronger. This is traditional notion. It's not necessarily correct. Okay? We do not believe surgery very much because it's this invasive procedure taking lots of time. The endurance for the patient costs too much. Okay? So my slogan is don't say surgery unless it has to be surgery. Okay? Take a look. And the special advices again, and that's the outcome with all the way that will be always great. So this is what the way that we now. Take a look. Now these are exemplary cases. If you look into further, we have to make sure that what's exactly the 3 depth malfusion etiology of the 3 depth malfusion, and then why that particular clear advice is so effective in treating this particular categories of the malfusion. Right? This is the contents that I want to describe in this first session. Right? Another one. What's that here? quite similar. That special clear appliance or special clear technology. Again, the clouding is quite severe. The clouding relief have a trivial task. We're not only just relief clouding, but also doing something that much beyond or bigger than clouding relief. Alright, so this special clear appliance or this special clear technology is we call it SHSGTB or SHSGTB technology. Okay? Now, take a look. For that one, we have several subtitles. Right? First of all, if we want to make it clear, we want to know that SHGTB treat that malfunction with facial convexity, we should go through these topics. Okay? First of all, clear SHGTB predecessor. You have to look back to the history, okay? What the things that we did for my team. We did a lot of work. It's not like all of a sudden we have the appearance of SHGTB. Before the emergence of SHGTB, clear SHGTB, we did lots of work. Right? We call it the predecessor of the clear SHGTB. Born SHGTB. Born SHGTB, differing from the traditional TB, is that the upper piece of bone are fixed to the maxilla permanently. Therefore, there's no way patient can move it away. Okay? The lower one keep the removable form, that doesn't matter because the patient has to be wearing the lower piece together with upper one. Otherwise, there's no way patient will chew the foods. Right? So there's two things here. One is the length of wearing time. The length of the wearing time has been secured for consecutively for 10 months is one thing. Another thing that the patient have to be wearing it all the 24/7, including meal time. When they're eating foods, they have to be wearing that particular appliance. Okay? So differing from the traditional removal one, which doesn't work very well, right? This one is a breakthrough. I invent that form of TB. We call it SGTB. Right? The upper piece is permanently fixed to the maxilla. Okay? We take the traditional there's a lot. I mean, the old case, we did that 10 years ago, 15 years ago. Very numerous patients have been colonized with that one. Although they have a lot of shortcomings, but they build up the base for the invasion of clear SGTB. The boy, 13 years age, take a look at the facial appearance. Okay? Facial appearance is such that upper, the middle face, okay, this part will be quite reduced together with a very deep labial dental fold. The prominence of the chin is quite not too bad. Okay, it's a strong indication there's something wrong with the position of the mandible. Be clear, right? The maxilla doesn't work. Mandible is mobile, right? Mandible is mobile. It could be permanently deviated from its correct track, right? So because of the time constraint, I cannot go through too much details of the position of the mandible. Right? Intraorally, again, we have a three-step solution together with what? Plus 2 molar relationship. Upper front teeth, very poor climb, leading to an increased overjet together with protrusion of the mandible positionally, leading to a more increased overjet. Right? Good. Of course, there's something. And also take a look, because the time constraint, we can't go through too much about the details of morphological analysis of mandible. Right? We call it, this morphology of mandible, we call it the rectangular and flat. Right? So morphology of the mandible is very important, rather than just measuring lots of regular, angular, and linear measurements. Right? Morphological analysis of the mandible. Right? Good. Okay. Reclined, low mandible plane, angle. If you look at the cervical, I still have some potential breath, but actually we don't need actually. Okay. I will talk about later on. Okay. Now take a look. OPG has a lot of information, including the depth of the curve speed. If the lower incisal line is curved, it's a strong indication the deep curve depth of curve speed is very excessive, very deep curve speed. Okay? I will mention that later on. Alright, so for that kind of patient, very deep, like a 15 years ago patient, very old patient, more than that. We are not having any teeth pulled out. We are not doing mental discoloration. We are not sending the patient for the future surgical limitation. What we did is a placement, designing and placement of a bond HDP. Alright, upper one is fitted to perpendicular to the upper one and to the maxilla. Lower one is removable. Okay, a patient have to be very 24/7. There's no too much possibility that a patient will just only wear the upper one, because he or she doesn't feel very comfortable if the lower one is not in place. Alright, and then at the same time, you can like 5 minutes into the treatment, partial bonding with the upper front teeth, starting the retractional alignment of the upper front teeth. This is also, this is the procedure that we always did with the bond HGP, right? But for the lower ones, we could do nothing. We could do nothing either for alignment or for curve speed flattening. There's nothing that we can do because there's no way that we can manipulate the lower additional teeth because the removed one piece is still there, okay? Right. And like 10 months into treatment is the time that we remove the bulky from the HGP, having all the rest of the teeth bond with braces. Right? We start with the frontal one with the bond. We should have replacement of all the braces teeth. Okay? But there's one thing that we feel very surprised that the time we remove the bond HGP is also the time we feel quite surprised that the open part, the umbilical segment, is very big. Right? It's very big. But this space was not created by HGP per se. It's not created by HGP. It's indication of the depth of curve speed. Okay? So take a look. This space is the space that we have to close up. With the closure of that buccal segment space, we are doing the flattening of curve speed. So there's something that is very important, or a very important clue for us to think about the correct way, or proper way to flatten or correct the deep curve speed. Okay? We're not doing anything struggling in the teeth to do. We're changing the position of the mandible first, and then we have a correction of the deep curve speed. Okay? With several changes arch-wise, the space will be closed. Alright. And then, with closure of the space, will also do some traction of the front teeth. And everything, the whole thing is changing very dramatically. Take a look. Take a look at the another animated explanation. That's the correct way to flatten deep curve speed. We will not do traditional way, having a mill, having a reverse curve arch wire. Okay? If we don't change the position of the mandible, it's all a waste of time to try to flatten the curve speed. Take a look. We have to move the mandible forward. Leave the totally exposed the deep of the curve speed, depth of the curve speed. Alright, and then with intrusion of the lower sides or extrusion elongation of the lower posteriors, we are closing up that space together with finishment or fulfillment of the collection of the deeper curve speed. Okay? Yes. All right, we're always finishing that way. If we look back, it will be taking much longer time using on the SGP than we are using the KSCT. So the fulfillment of the patient would be always such a acceptable, even more than ideal. So not only the intercostal relationship, but also the relationship between upper and lower condition in terms of the overjet, overflight, and depth of curve speed. Okay? Yes. So take a look at it again. We'll finish the test in such a way, and then we finish it. As a model analysis, we together with Twinblock +2 relationship, and we finish all these anomalized being corrected. Twinblock relationship has been changed from +2 to +1, and also overjet over depth of the curve speed also corrected very beautifully without any sacrifice of any teeth. Without too much normal distillation. And at that time, it cannot be realized with twist rises. And take a look at how deep the overjet is. The lower size will be pointed against the cut directly. And also give us a clue. Alright? Yes. So the curve speed, the depth of curve speed is created by the elongation of the lower incisors together with intrusion of the lower posteriors. Because of the position, the change of the position mandible from correct position to intrusive position. Okay? This is the way that we need to have. Okay? We have so many patients having 3-depth problem. They may not complain, they may not be formed by the appearance, but the 3-depth malfunctioning is a very severe anomaly in human being, right? So we should have the mission to correct it all in a proper way. Alright, so this is a very universal and it's a very regular sort of the correct approach to have 3 staffs at least original in the middle of treatment after finish of the orthopedic mandibular relocation and finally after total completion of the face. Okay? And what we could find is a low incisal compensation. This is a fatal shortcoming. Right? With the bond HDB, although the efficacy is not too bad, but if we take a look into these details, you'll find that there are lots of shortcomings or pitfalls. Right? The most important or most discouraging pitfall is the proclamation of the low incisors. The anchorage control is so poor that the low incisor would be proclaimed at least 5 degrees. Although naked eye, you can't find it very obviously naked eye, but with the measurements, with the several measurements, we found that the proclamation of the low incisors would be more than 3 degrees to 5 degrees or beyond. Okay? The more the proclamation of low incisors, the less of the real repositioning of the mandible. Okay? Take a look, we are not satisfied, although the proclamation of low incisors will be having automatically upright with the passage of time. But immediately after treatment, we will always find that the low incisor compensation is quite evident. Of course, the facial appearance will change just dramatically because of the reposition of the mandible. If suppose we don't change the position of the mandible, don't have the dentitional camouflage, the facial appearance will be not having such a sort of ideal change of the facial appearance, especially for the mandibular area. Okay. And control the way. We have a long time follow-up. It was 30 years of age when the patient starts the treatment and finished by 50 years of age. And we have first time follow-up will be 2 years after treatment. We have a quite a good ideal like maintenance of the accomplishment. There's no too much change in terms of the relationship, indicating the mandible is not going back up again. Okay? And then recently, 12 years after treatment, we take a look at the patient again. The molar relationship is still very stable, right? It's very stable, indicating that lubrication of the mandible is very feasible. The facial frontal view, together with facial frontal view, lateral view, okay? The escalation of facial appearance doesn't go, right? They don't go, because always there, right? So this is something that patient much happier for the change of the facial appearance than the change of malocclusion. They don't know too much about malocclusion. They know too much about the facial contour. They have lots of publications with it. Today, if you look into the publications with our team have already published. Okay. Now, first of all, this is a predecessor of the one that we present later on. Okay? We have been doing front HTTP for more than 15 years. Build up a database. We have treated front HTTP for numerous patients. They are all very good data, right? But having said that, we also have not very satisfied with the results, especially something wrong with bond HTTP. Right? Take a look. The bond HTTP bulky causes lots of discomfort to the patient who always complaining about the problems, right? Of bulges of the eyes. For oral hygiene, especially if there's no any element of digitalization. At that time, there's no digitalization concept. Digitalization. They have to manipulate every procedure. They have to put the braces on, instruct the patient to wear the orders 24/7. They have to wait for like 10 months before we can put the braces on the loading sizes. Right? So there's not any element of digitalization, not mentioned. Algorithm, okay? So there's the working efficiency is very, very low, very poor, okay? Taking a long time. The average for one HTTP would be more than 2 years, even 2 years and a half, in some cases exceeding 3 years, okay? And also very difficult when the time you have to remove this bulky piece of bond to the one, very adhesive. You take a lot of time and energy to remove it away. Parents will be all complaining about such endurance that their children have to go through. Okay? So this definitely is no good food. Time that you remove it, I always escape from the scene because it's very savage. Right. So they are all inspiration for my team to create the clear version of SGTP. Clear version of SGTP. Okay? What's clear version of it? Similarity between these two structures in terms of the physical form, right? But because this is acrylic mass, this is what? The plastic sheet changes happen. Huge change. The disparity between these two forms are huge. Because with that bulky acrylic, we do nothing about the digitalized procedure, right? But with plastic sheet, we can incorporate some digitalization elements to that clear alignments. Huge, okay? Now, the structures, we take a look at it here, okay? Of course, in the upper frontal, in the upper piece, we have the two occlusal blocks, two occlusal plane. But these two occlusal planes are not physical, just a physical form. They contain lots of information which have been built in beforehand, right? And also take a look. The occlusal surface of this occlusal plane is such that they have anatomical structures mimicking the natural structures of the teeth, natural teeth. Exactly the same, very sharp. The anatomical indication is very sharp, right? In this area. They have a dentition, they have the anatomical structure exactly the same with their natural teeth. And in the lower matched surface, they also have structures there. Right? Imagine how convenient for the patient to chew foods with this appliance in place. Rule number one, you have to instruct the patient to eat foods with that appliance in place. That's rule number one. Okay? There's no discontinuation. The only time that the appliance can be removed from the mouth is the time to brush teeth. Otherwise, they'll be always there. Trust that the ability and the adaptive ability of the human being is very crucial, right? So with this sharp indentation, there's no difficulty for the patient to chew the foods, to have the meal, to have even some portion foods, some very block foods. Right? So in terms of that 24/7 wearing, we have fixed appliances. There's no two difference between fixed and what clear aligner. Clear aligner is not removable appliance. It cannot be falling into the category of the removable appliance because they have an attachment. Right? Removable appliance doesn't have attachment. The cluster sometimes doesn't work. But this one, when you simply attach it, if that clear aligner is incorporated into the attachment, is fixed appliances. Unless the patient will have to remove it or brush it, or teeth brush it. Okay? So the concept very much. Removable appliances and removable appliances, as the traditional one. But is not the category of removable appliances. In terms of the 24/7 wearing, is fixed one. Okay? And in the lower piece, we have a matched mechanism for blocking, for changing the holding of the change of the position. Right? So, individual and invisible. Okay? This the clear SA, differing from the routine clear aligner, which does not have any extra structure unless they have a basal form of a clear aligner. Right? But we have occlusals, the occlusal plane, and they also match mechanism there, making it so different from the routine clear aligner, which only just for the alignment, the blood release, or some very easy task. Right? Without any elements of change the location, positioning of the mandible. Okay? But it can, right? Okay, when they are in the place, suppose how tight between the upper and lower vocal segment with isolation of a clear aligner, a patient just feel like they are chewing or they are just has a mastication function like the natural teeth. Okay? And suppose again, you just suppose we are doing lots of movement. We are not just replicating the mandible cord, but also doing the individual teeth. Like the vocal segment in the lower teeth, we are doing upright. Doing lots of significant uprighting or something. That with the change of the position of the teeth, these structures also changing accordingly. Right? That's amazing. This algorithm, tremendous organism elements. Okay, patient has to realize there's change of the structures of the clear aligner. Right? Okay, so digitalization in algorithm, if the SGTB with precision, accuracy, efficiency, and predictability, right? So this is the physical form. Don't overlook the physical form. As long as the classical ones, we could have incorporation of lots of digitalized elements. We can design everything we need into the click miner, right? And this animates simulation, and you can see lots of cases, right? They're all changing. But one thing does not change is what? The lodgement, the tightness, attachment, the touch between upper and the lower clear items. Okay? Right. Clinical indication of the SGTB. Clear SA is totally differing from the traditional ones. Okay? Now, the indication is very complicated. Actually, the theory is very complicated, but we just forget about that. We have a classification of the application through that macrofusions with fusion convexity, but today we don't talk about that because time really quite constant. Okay? So we should go through directly about three depths. Now, if we forget everything, one thing you just keep in mind is three-depth phenomena. Okay? If you have a patient with intraoral three-depth maloclusion, is definitely for sure that they are falling into the indication for usage of clear S8 SGTB. Okay? So, with the clear SGTB digitalization elements and algorithm, when we put in place, we get the position of the change the position of the mandible together with the relationship between upper and lower division. Everything is changed, okay? Everything is changed as long as the patient can wear it for like consecutively for like 20 months. Alright, so mandibular for the repositioning by SAHGB. So SAHGB, another term for that special class of what call it mandibular form repositioning technology. We are not just changing teeth, we are changing much bigger or beyond the teeth, the condition what the whole mandible, right? So the answer is first of it, what do we do? The clear price is very like mysterious, a very mysterious price that we call SAHGB. There's no exception, okay? Not changing the position of the teeth, position of mandible, we also change the facial appearance. Again, we have SAHGB, and we also change the appearance of the face. And again, that's huge. Just like surgical is the same effects with surgical intervention. The surgical intervention goes to the root of the problem. Okay? All right. Let's begin. Change both file. Okay? So, SAHGB indication, summarization, very simple. Okay? First of all, three-depth maloclusion with facial convexity. That's one word, okay? Or one sentence. Three-depth maloclusion will always coupled with facial problem. Okay? And if we take into details, deep object, deep overbought, deep field speed together with molar plus stimulation, they are the indications of S8 SGTB. So in other words, such similar occlusion in your clinic, don't think about extraction teeth. Don't think about molar digitalization. Don't think about surgical. You have to think about S8 before you resort to other approaches if it doesn't. Actually, it always works. Right? Always works. Right? Alright, so we go to 3. The third subtitle, clear S8 SGTB and its working mechanism. How does it work? How does it work? Okay? Alright. So the working mechanisms is implementing correction of the nutrition while implementing manual. There's always two key factors simultaneously. And not only replicate manual, but we are also have a displacement of feet of the tissue together. Right? So the work mechanism, if we can spread it over, we have expansion, we have from the lead or alignment, we also doing curve speed flattening and also partial mobilization, okay? Partial, not total. Okay? So take a look at first. Maxilla or arch expansion. And give it like the last one. Take a look at the lesson. So the case first, okay? Yes. So why is transverse expansion is essential? We didn't go through the philosophy about the etiology of the fluid depth. Actually, this coordination between upper and lower condition transverse dimension is the first source of the problem. Okay? Right. So upper dental arch contraction is very common in fluid depth occlusion. Okay? With the contraction of upper dental arch or facial bone, what can happen is to reduce the positional compromise. The compromise in the mandibular position by shooting itself backward, not other way around. Okay? Too much. I didn't do too much explanation about the nutrition, positional nutrition manual. Okay? All right. So if we have three depth pushing, adding another way, another phenomenon, contraction or narrowing of the what of upper dental arch. Okay? Yes. So the contraction of the upper dental arch is always very common in three-depth pushing. Why? Because we do have a tendency between the basal bone and the dentition, okay? Which is that. The dentition will be getting narrow, and also these, like if we use three facial profile, we have a top profile, and you have a concave facial profile. The vocal segment teeth position are different. The first one is getting very inclined palatally and leading to the contraction of the maxilla. So the expansion of maxilla augmentation is always very essential. Right? Otherwise, the mandibular full reposition doesn't work. We can go back again. Okay? Yes. Alright, so transverse expansion is achieved either on mid-palate separation or posterior dental decomposition. In this situation, the decomposition other than the mid-palate enlargement. Okay? But sometimes, because of the basal bone contraction, we have to do what? You have to separate the middle part. There's two forms in terms of transverse expansion. Okay? Sometimes we need mid-part suture separation, sometimes not. Only decomposition of the vocal segment. Okay? Right. On this page, the facial profile is very protrusive. Again, where three pushing is formed in the very early stage. Okay? The early stage for facial formation is at the primary dentition. Okay? So, very deep, three-depth fusion will be probably supernumerary tooth everywhere. We could mention that. Okay, so how do we do? We have a separation of the mandibular forward movement and take a look inspection of the vocal segment if the space is big enough, indicating that the speed is very deep. Okay? And the mandible for morphology mandible is good. And the deep curve speed will be getting severe with the passage of time. The older the patient is, the deeper the curve speed. Right? Because they take time to have an elongation of the incisors to get the intrusion of the lower posteriors. Supernumerary or something. We have a SI taking place. what we do is to relocate the mandible together with some extension up the front teeth without using S11. We haven't had S11 yet, right? Because the age is in the pubertal skirt period, it's very sensitive. The mid-palate suture is very sensitive. As long as there's some force against it, it will be enlarged, right? And then this is the lip balm part here, lip balm part to have a reinforcement of anchorage in the lower incisor, preventing the lower incisor to be reclined. Okay? And when we finish that, we have a correction of this 3 depth together with depth speed, but we have to wait. The earlier you start the case, the heavier your task will be, right? So for this kind of a patient, this doesn't matter. It's early treatment or later treatment. It doesn't matter. Because when you start the treatment for SHBG in such early age, like 9 years of age, with like the 1 year or 10 months, you finish the first stage, and then you have to wait for the exchange, for the permanent teeth eruption, right? And then you can start the second stage. It takes a long time. I don't know. In China, now it's very popular, the earliest age treatment, because they want to grasp the patient as many as possible. But keep in mind, the earlier the patient be treated, the heavier of the responsibility. Okay? So we have to wait for the second stage after permanent teeth have been erupted, because the task is not very because we only have just trust the SHBG. The accomplishment that we finish this stage will be transferred to the next stage. Okay? There's even no occurrence that the man will be set back again. Okay? Yes. And what we do is enlargement, extension of maxilla, right? And the effects will be very much the mid-palatal suture separation at this stage. Treatment. Yes, because we are changing the facial appearance again. The only bad thing about early treatment is that it's a long battle. And you have to wait, you have to keep observation of the eruption of the permanent teeth, and when the time comes to such that permanent teeth are all there, and then you have the second stage, you have to cut the alliance again. Right? You have an intercostal relationship correction in the line, everywhere, okay, everything. Okay. The mandible morphology is good. This is the flat and the rectangular. Okay? We never call it low angle, every angle height. It's not accurate. Okay? We have just have a morphology analysis. All right. So the curve speed will be, if you don't treat at this stage, the curve speed will be getting deeper when the permanent teeth are coming through. Okay? Have some advantages of having treatment at an early age that we don't refuse to recognize there are some disadvantages. Okay. Adolescent. Take a look at adolescent case. Boy, 11 years of age. Almost after the pubertal spurt, the middle palate suture is still very sensitive. Okay? They are always in common in terms of the facial appearance. Okay? There's a very deep fold, deep ligamental fold, and the dominance of the chin is not bad. There's nothing wrong with the morphology of the mandible. There's something wrong with the position of the mandible. Okay? So you have to keep in mind. In terms of mandible, you have to look into the position, not only just regular, angular, or linear national. Three depth, last two molar relationship, very contracted upper pancreal arch, so with contraction of what? Of the basal bone. Okay? The morphology of the mandible is correct. Right? The pronominance of chin is good, but the position is backward position. leading to 3 depth. Now I have to give you a clue, right? The mandibular positional nutrition is the source of the problem for what? For 3 depth. So 3 depth is formed because of the nutrition of mandibular position. Yes. Emma, we finished. Okay? So it's very, very important when we're doing the SHTP, don't forget the expansion of the maxilla. But the advantages of the SHA is that they do all the things together without wasting any single day. Okay? They can either do the expansion together with relocation. When the mandible is really headed forward, the expansion is doing is implementing. Good. Of course, we have a good facial appearance change. Suppose that if you just imagine if you just have a divisional kind of flash without changing the position of the mandible, we could not have such a beautiful appearance change. Okay? Right. Now, good news that we have S11. S11 is we have a structure connecting both sides of the aligner. S11 is very useful. It's also digitalized design. The curvature of this S11 will be set beforehand and will be with change of sets of the aligner will be going to when they enlarge the position, the curvature depth of the curvature getting a bit flat, and then the next set will be a restoration of the curvature depth, and again the exhaustion of the enough adequate force against the two sides of the position. So it's working very well. Alright, so maxilla expansion is very important. Very important. People with young adults can be non-used although she is very, it's adult, but we still, S8 is still workable for adult, not only for children, but for adults. So, looking to intraorally, again, we have contracted the upper frontal arch together with class 2, together with 3 depth. They are coming together. They have a concomitant appearance, okay? Let's say again, 5 action. Increase over jet, increase over 5, increase the depth of curve speed, class 2, and construction of upper and arch. 5, okay? Phenomenal. So we should do the proper collection of the 3 depth, and not only is collection of the 3 depth things, we also have the collection of the narrow or contracted upper and arch. Okay? Mandible is good. Curve speed is very deep. If the curve speed is flat or flat, it should be a flat line. Okay, there's no curvature of that line. Okay? Yes. And I have to say, because we don't have time to describe the condyle or TMJ today. Okay? Look into the TMJ because this is big occlusion. Dentition is small occlusion. Okay? Big occlusion is that it's more important than additional occlusion. You have to tell the patient that has a situation of condyle and TMJ before we start the treatment. Okay? Right. Placement of the S8 actually is the early version of the S8 SGTP. At the time, we didn't have the occlusal anatomic structure yet. So we are doing expansion together with what? Together with partial molar crystallization sometimes, intrusion of the lower incisors. Okay? And what we have is that we are correcting not only the position of the mandible, but also the flattening of the curve speed, because at that point, with the finishment of the first stage, the space in the bottom segment is still there, no worries, okay? What we finished is the expansion of the upper dental arch to be finalized. And further, the the closure of the focal space. And take a look. Upper Twinblock position without necessity for the middle palate separation at this case. So expansion of the maxilla is so imperative, is so critical that we have to do that. When you design the SGTP, don't forget, because it's a set course. If you set a case too smarty, it will always automatically have a designing of the expansion. You don't need to worry about that. You have to understand the philosophy behind the expansion. Finish again. Yes. 3 years or 5 years or 15 years or whatever. As long as you can follow, the results will always be very stable. Be it children or be it adults. Now, what we have making us very satisfied is the control of the loading size is huge. The full coverage of the clear liner itself is enforcement of the anchorage, and also we have lip pompa incorporated into the clear liner, and finally we could have placement of the screw in the mandible, at the side of the mandible. Right? So the control of the loading size position is much better than the on the SGTP. Okay? How is product relief achieved? Let's say again, transverse expansion, transverse proclamation, posterior distillation, IPR implemented simultaneously, working together. Okay? 32 years of age again, kind of it's a young adult. Particularly control way, the clogging is very evident because of the retroclavian upper lobe is thus leading to the clogging of upper frontal dental arch, and these two canals are totally outside the dental line, indicating the severity of the clogging. That no matter how severe the clogging is, as long as it is a 3-depth malocclusion, don't extract the teeth, right? Before you have a trial, before you have a design, okay? Before you send it to the smarty, they will have the assessment. Now, the contraction of the upper dental arch is very evident. Okay? So with the placement of the SGTP, what we did lots of things together. We have a molar crystallization, we have to do that. Although we do not rely on the molar crystallization fully. We have protractation upper front teeth. We also have expansion of the upper dental arch, and we have IPR, right? Creating adequate space for crowding correction for this particular case. Right? The stage 1 finish is the time that we also have a huge change of the crowding. There's still have some remaining tasks, okay, and also open space we call the set. Don't worry about the space. Okay? Space will be closed anyway in the second stage. Okay? So the second stage is the closure of the space again, and creating some more space for the proper space, right? And then creating some more space and some more distillation, make sure that the space, the total space will be quite adequate for the clouding relief. Okay? Yes. So, because with 3-depth malocclusion, if you extract the teeth, you are inviting lots of trouble. Right? Right? Okay, so what we did, it's a very difficult case actually. Because we have some change of the patient profile, but intraorally, it's really quite a difficult task that we are facing with such a severe sort of situation. Okay? Yes. Okay, now the third working mechanism is curve speed flattening. Okay? Take a look. Now, first of all, how is the curve speed is created? We didn't do too much elaboration on this topic. Perpetual mandibular retrusive position. Okay? We have 3-depth malocclusion. The 3-depth is caused by retrusive translation of the mandible permanently. And with the retractable mandible, translation of the mandible, what happened? Class 2, class 1, change to class 2, right? Increase the reject. And also the lower incisors being taken away from attached with the upper on the top. Then we have the elongation of the lower incisors. And all the mastication also are concentrated on the upper segment, leading to the intrusion of the lower incisors. This is the formation of speed. Okay? So first, the source of the problem is the intrusion of the mandible. Okay? So how does the curve speed is identified? You have to identify the curve speed. Deep objective overflight not necessarily coupled with deep curve speed. Okay? But if you have a depth of curve speed, it must be have a deep object. It's very philosophical. Contradictory but philosophical. Okay? Now, if you have a very obvious deep object, deep overflight, it's not necessarily that patient have a deep curve speed. Okay? You have to have a test. You have to instruct the patient to forward positioning his mandible to edge, incisal, edge to edge, and have inspection about the amount of this open space in vocal segment. If it's beyond like 4 millimeters or it's quite big, indicating curve speed is very excessive, it's very big. Okay? Otherwise, no. If there's no space, or space is very minimal, it's very tiny, the curve speed is flat. So this action is also the action that we pay attention to. Okay? Now, one of the most important goals of the SAS is to make that position permanent, not intermittent, not constant, right? And not instant. It has to be there. Now, you move the mandible forward, place some speed there, and we have a placement of SA for like 3 months, and then the mandible will be permanently set there. Okay? Yes. All right. The second is take a look at the mandible morphology. It's always flat and rectangular, and also that way. The OPG, you can have a measurement. The incisal line is very curved. It's a suggestion of the depth of speed. Okay? It's very excessive. All right. So how is the curve speed is flattened now? Now, the source of the problem is the positional retrusion of the mandible. Now, if we want to collect the deep curve speed, what should we do before we do anything else? Move the mandible, restore the mandible first, before you do the additional camouflage, not other way around. Okay? You can bend also the first curve the arch wire, or you change lots of like a mill or something. Doesn't work. If the mandible is still kept in the retractable position, there's no way that you can correct the curve speed. They're all false. Okay? Take a look. 12 years of age. Read that again. Curve speed is very big. Mandible is good. Right? Again, you have to similar. Okay? And the curve speed, how big it is. Very big curve speed there. Right? So the flattening of curve speed, again, you have to change the position of the mandible before you could have the correction of the deep curve speed. I said again. Right? So we have A-side, it's a very early patient. And take a look at what we do. We did lots of intrusion of the lower incisors. Now, we have lots of intrusion of the lower incisors. Again, this is a very early patient. We did not have a procedure for gradual reduction thickness of the approval domain. Right? So the curve speed is mainly collected by the intrusion of the lower incisors. And then leave the space again, and then leave the space closure. We're also doing elongation of the lower posteriors. So we finish the second stage, and then we finish the phase with the first flattening, and all the way again, do all the things together. Right? So then the curvature from the flat. The lower incisors are controlling the position. What we have in the position, not only this teeth of correction of malocclusion, but also outside the occlusion, the drastic change of the facial appearance, which will be always received well by the patient. They are paying more attention to the facial appearance than the malocclusion. Okay? All right. Initial 3 years follow-up. Stable. Okay. Good. All right. The deeper curve speed correction, we have an adult test again. 38. Age doesn't matter. It doesn't matter for the age, right? For the weak positioning technology, age doesn't matter. No matter how old the patient is. You guess what's the oldest patient our team is treating? 68. 68 patient is still working. Because I do not mention that the captive remodeling will come out because it's fine, really, right? That is happening, okay? Good. Don't only treat the kids, you have to treat the adults. Okay? How big it is? Okay, we have two that take a look. If you instruct the patient to move through huge space, no matter how big the space is, they're always quickly corrected for S8 because we are not treating the patient with only the teeth, but also positioning the mandible, right? So in the radicular pole positioning, it's definitely will have a good results for the correction of the deep curve speed, no matter how severe the deep curve speed is. Okay? Morphology is good again. We do that. Right? Speed, placement. This is a gradual or progressive procedure for the correction of the deep curve speed. We could either have intrusion of the lower incisors or having an elongation of the posteriors, depending on lots of the factors. Okay? And then we have in front of you, we have closure of curve speed is also a closure of spacing is a correction of curve speed. We finish such a case, such a severe case, will be everywhere. The patient goes to everywhere. The only answer is always uniform. Surgery. Do we need? I can clearly tell you guys, okay? As long as it's a 3-depth malposition, there's no indication for surgery whatsoever. Okay? So speak. Flattening. Again. Alright. 3 years follow-up. Also very stable. Stable. Good. Okay. Now, we mentioned that the correction of the curve speed is by 2 entities. One intrusion of the lower incisors, another one is what? Elongation of the lower posteriors. They have to proportionate. Okay? Depending on the patient's own thoughts, especially the height of the lower face. Okay? The lower face height could be increased or affected by these 2 entities proportion. The more you intrude the lower incisor, the less that you can affect the height of the facial lower height, right? The more you elongate or intrude the lower posteriors, the more likely the lower facial height will be increased very dramatically. Right? You have to notice that. Right? Okay. So we have a review here, okay? When the mandible is moved forward permanently or even without the permanent, okay, from the day 1 we have to start the collection of the deeper curve speed. Now, the deeper curve speed is indicated by the buccal space when the mandible is moved forward, okay? And then the task of the correction of the deep curve speed is the task to close out that space. The space closure in this particular area could be realized or achieved by either retrusion of the lower incisors or extrusion of what? Lower posteriors. The proportion between these 2 entities is such that you have to ask the patient's opinion, right? Especially the facial height change. That patient is a patient who is not happy with the occlusion, but very happy with the facial height. She doesn't want any change in the facial height. Okay? Now, if the patient in your hand with 3 depth, and you have to face with the proportionate balance between intrusion and extrusion. So how do you do? The patient doesn't want any change of the facial height, so you have to intrude the lower incisors much more than intrusion of the lower posteriors. It can be realized with both SGD cannot get that. With that one, because we design everything beforehand. Right? So we have a clear aligner design in such that we are doing most of the way with the intrusion below incisors without any change in the thickness of what? The global plane means that the elongation of the posteriors is very tiny. Okay? Right. So the curve speed it will be flattened anyway, but in which way is very, very tricky. Okay? So in this case, where intrusion, we do less intrusion below incisors. Okay? And for some other cases, they demand otherwise. Okay? They want change or increment of facial height, and what we do is to extrude the posteriors much more than intrusion below incisors by reducing the thickness of the occlusal plane gradually. Keep the below incisor there, and reducing the what? Gradually reducing the thickness of the plane, leading the elongation of the lower posteriors. So you do everything. So you have to, when you send the case to Smarty, they have a routine setting procedure. But if you have a special demand, just write down. Okay? They will be implementing your demand. Okay? Now, molar distalization, I said that molar distalization is not reliable, but sometimes partial molar distalization is still necessary. But we no longer rely on molar distalization to correct the discoordination between upper and lower condition, because the discrepancy between the upper and lower condition is achieved mostly by the relocating of the mandible, not by the dentition. Okay? Say again. Okay? If you have a huge increase of jet, we either have the molar distalization or have what? It's much easier actually. So it's injecting, not what? Not the injecting, not predominant. Okay? Because it was this that girl, you know? We have to speed up times. Okay, we have again. Yeah, we have SGSPD. I think we have a partial molar distalization to make sure that the overture, we still have some overture there, okay? Because when we move manual forward, either edge to edge or some like 2 millimeters overture, expecting that we have a molar distalization to have retraction of the maxilla. Anyway, it's true. Right, so we have a partial molar distalization to decrease the overjet remaining overjet 2 millimeters. Right? So we could have a partial distalization, and then we finish the case. You can move the manual quickly to edge, but sometimes it's not. By just a simplest way to edge to edge. But sometimes if you have special demanding, you look at the manual such. There's 2 millimeters of overjet still there, right? And the correction of 2 millimeters overjet will be achieved by molar distalization, right? Okay. All right. So we just skip it up, and also the changes. Okay. Now, why is molar distalization is adjunctive but not predominant? Say it again. Most of the discrepancy between upper and lower jaw is achieved by relocation mandible. Right? If you have only several millimeters of overjet there, it could be achieved by accompanied molar distalization. One years of age again. 3 depth again. Deep curve speed. huge problem in this particular area, so we design such that motor solution in this particular area is much bigger than other areas because we have to create space. Okay? So we are creating space by multi-pixelization, and finally, like a crowd relief in this particular area together with the integration manual together with the space over here, and we are finished that phase. So the most of tasks are implemented simultaneously, okay? Not phase by phase. Such severe problem there. So we finish in perfect way, almost perfect way. Good? It's getting longer because the change of position, not only change the manifold position, you are changing the whole posture of the human body, of the whole body. And if we implement of other air space, I didn't mention that. Alright, so we have a summarization, extension, alignment, planning, model visualization, everything. At the same time, we are doing the change of the mandibular position to restore the correct position of the mandible. At the same time, we do also displacement of the hidden teeth or the whole condition. We have a typical case. Take a look. We are all working together. 10 years old boy. Recap. Okay? Recap. Of course, you can correct that in such early stage. The advantage of the early treatment for that particular case is that the push is too severe. Alright? The long time that they have such medication, the adverse effects to not only the malfunction, but also the whole posture of the head, and also the airway space, like the air space now, right? Even if some small or something, and so we do. How big it is. Don't be afraid of the space. The space is giving you a chance to correct critical speed. Right? The simulation. That becomes an encouragement. Such a change, yes. But day one, the SIT in place, it's huge change. If you want the change permanent, you have to instruct the patient to have a good compliance. Right? So speed has been already up. Placement, what do we do? Lots of things, okay? This is the summary case. Actually, with the extension, with the priority, we do the reduction of that errors not yet, and we also doing IPR, everything, right? And nutrition with low slices. Huge change. There's speed, the mandible, fraction with a few years of the follow-up, so already 14 years of age, very stable. The boy was lucky because when they start treating the preventive for limited. So my suggestion is that next position is not very stable. You have to change, you have to re-scan the condition all the time. As long as the pivotal state come out, it will be pretty fine. Okay? Of course, for the most severe cases, exception. Okay? All right. All right, for adults, habit of adult. This is very severe. Now, if the patient misses the chance to be treated in the early stage, don't worry. At 23 or something, you still have an opportunity to practically treat. As long as the doctor knows the knowledge of the JS knowledge. Okay? How severe? Makes it worse is what is the seizure spikes in this area, terminal site. Now, for the terminal site, this is what is always hepatic, for orthodontics, but don't worry, because S8 is exactly one of the advantages to treat since void, because we can open the void. Right? Okay, so we deliberately open the void deliberately excessively with the frontal incisor open by like 2 millimeters or 3 millimeters in order to create exactly the space in this area of the question. Right? Right. If you like, multi-crystallization, reduction of the thickness of what? Of the thickness of the rubal plane is reduced, indicating the elongation of the lower posteriors, leading to the flattening of curve speed. The most important thing is that the series was being corrected with too much effort. All right. Sorry. There's a hasten. Fine, really quite needed. All right. All right. So the second stage is easier. We're doing some constipation, deliberation, and then we could finish that case in such a beautiful way. Again. Right? So either kids or adults, they are all indicative for S8 as long as the malfusion, if we get malfusion, right? And we have a change of the TMJ model. Just keep that part, supporting the new position strongly. Okay? All right, protocol is very simple. We have 2 stages actually. Okay? The stage 1 is the one that we relocate the mandible is the emphasis. Okay? This emphasis of the relocation of the mandible is the stage 1 main task. At the same time, we can certainly small things. Okay? This stage 1. Just like that one, there is still that too much. Yep. And then we have stage 2 is all stage 1 followed by stage 1. You can scan the condition again, just very simple. The second time, they scan and then sample. They will have some several steps for transition between stage 1 and stage 2. Stage 1, the transition period is a period that you have the appliance which will not have any teeth moving, okay? And then you send the data, and the second stage appliance will be coming back, and then you start the second stage. Stage 2 is further leveling the speed together with the intercostal collaboration. We're always finishing this beautiful way. Okay? Good. All right. Okay. Now, how can we do that? The positioning, the new position of mandible has to be recorded. I can try, determined, and recorded. That's very simple steps. You guys, I hope that you guys could learn about that and start your first S8 as soon as possible. Okay? Right. Okay. We have mandibular forward wheel positioning, stimulation, determination, and wax recording. Very concise and simplified protocol. Okay? Take a look. 4 steps. Just 4 steps. Step 1 is you have your assistant to intrude to have an entire dentition scanning, right? To record the structure of the upper and lower dentition isolated. If it's possible, also have a scan of the palatal tissue in case you use S11. Okay? This first time scan. The second step is to have a trials of the new position of the mandible. You can try, right? You can take several times to try to make sure that the final position, new position is the position you divide. Okay? So this second step is to decide the mandible new position. The third step, you can have the wax, segmental wax there to place in the frontal area to hold the mandible new position. With that holding the new position of the mandible, you have second time scan to have to scan what? The new position of the division and the new position of the mandible. Yeah, take a look. 4 steps, okay? First step is to have entire dentition scanning to record the structures of the dentition. Say again, don't forget the cavity tissue. This is GS, so this specifics, okay? You can have the S11. In the middle of the treatment, maybe there's addition of the S11. If you don't have the data, the S11 cannot be fabricated, okay? The first step, that could be done by your nurse or by your assistant, not yourself, okay? And then you come back to the chair side, okay? After the completion of the first scan, and then you sit down to the side of the patient and to have that simulation of the new position of the mandible by instructing the patient to move the mandible forward, to open a little bit, to take a look at how big the opposite space is, right? Now, the new positioning mandible, there are some criteria. Right? Now, the new position of mandible criteria is very simple. Okay? And this is vertical. You can have the handrail. You can have a handrail of your mirror to ensure that how much the box space is. Sometimes, because of wearing of the lower accessory, something the technical capacity is necessary leading to a bigger space. But the space is such that we have 5 millimeters at least, 5 millimeters, okay, to accommodate the approval plan. Now, when the mandible will move forward and close up the incisors, the space is quite enough, leave it. If the space is not enough, you have to open the front teeth a little bit. The maximum is 3 millimeters. Patient could feel comfortable, don't worry. Okay? Close up is better, but if you have to open the front teeth 2 to 3 millimeters, it's okay. Okay? Right, okay. So 3 simplified criteria to define or to determine the mandible for the repositioning. Sagittal, advance the mandible to incisal edge to edge. This could be very easy to memorize, right? But sometimes, if you want to finish the case in a much beautiful way, you have to what? Defer between based on the frontal teeth. There are 3 scenarios. One is procline, one is straight, and one is what? Intercline. For the procline, with the pattern, use the mandible forward, leaving 2 millimeters of jet. But if you forget that, you forget that, okay? And for the other 2 scenarios, edge to edge is correct. But anyway, if you think it's too complicated, edge to edge, nothing too much wrong, okay? If you have the first scenario, you have the procline, upper front teeth, and you use the mandible edge, is a little bit excessive. But Smarty will try to manipulate the dentition to make sure that the front teeth is going back. Okay? Alright, so edge to edge. And then vertical 5 millimeters. Just look at the posterior. It's big enough, right? That's what? Okay? Transverse. No deviation of the mandible. The chin point will be overlapping with the facial, regardless of the dentitional situation. Okay? Just take a look. It's not, okay, the mandible is not deviated to either side. That's fine. Right? So 3 criteria. Okay? And the third step is wax placement. You have to determine the right position of the mandible, European mandible. Now, you should make a segmental wax. Just like the part of the arch form, okay? Covering 3 to 3 or 4 to 4, quite enough, right? You cover the segmental arch form of the wax can only place in the labial segment, right? Labial segment. There's no need to cover the whole dental arch. I suppose you guys have the auto scan facility. No longer use PBS, right?
để lấy dấu.
Okay. Right. And the wax placement is such that it's placed behind the front teeth. The front teeth have to be exposed totally without any obscuring something. The wax cannot be come out of the position. You have to be very clear. Keep that position area very clear in order to adjust the new position of mandible or adjust the position between the relation between upper and lower front. This area you can only look into to determine the new position of the mandible. Okay, right? So the wax is the frontal area is very clear, and the leading. So frontal area is the area for adjustment. The area without the coverage of the wax is for second time scan, right? Second time scan is the only scan that both sides of the area here. No need for scanning of the new position of the whole dentition again. Okay? Now remember, the first scan, dentitional structures. The second scan is the new position of the mandible. Okay? When you determine the position, when you put the wax in the patient may sometimes the patient is very clever, sometimes it's not very sensitive. You have to ensure to move the mandible forward gradually. As long as the mandible is moved forward, there's no way to retract it back again. Okay? And when you move vertically, you instruct the patient to attach with the lower teeth with the wax. As long as the lower dentition is being attached to the wax, there's no way to dislodge it again. Okay? Just several times. Until, because the frontal area is very clear. It's very clear. You can manipulate the new position whatever you want, but don't take it too much time. Okay? Right? And the next step is step 2, have a scan of this particular area to record the new position. And immediately the digitalized imaging will be formed and smoothing. We have that new position, including this area very important, accountable, including the whole thing. Okay? And then based on that imaging, we will have a application of S8. Right, review. Summarize it here. Okay? We can make it simpler. It's the simplest way. Yeah? Alright. Step 1. Dental structure. Step 2. Trial. Right? Trial. You have to try a new position. Right? Step 3. Placement of the wax. Right? Step 4. Scan again. And then finish. 4 steps. For this particular step, you have 3 criteria for the determination of new position. Okay? Sagittally adequate. Vertically enough space in the buckle. Transversely there's no too much duration of the change. Okay? That's it. Alright, I hope that you guys already memorized that because it's very important. It's very practical. If you want to start the case, it's very simple. Not be afraid. Okay? Very simple. Okay? Good. Alright. Okay, so we finished the first session. We should have 2 courses, or 3-day courses. We only do, because you guys demand the class 3. Otherwise, it's too much. Okay, we have to finish this first session, and the second session is about the other way, class 3. Okay? Thank you guys very much, and we will do have some question time. Okay? Thank you. Yes. Because it's too intense. Also too intense. The other side has enough. Okay, good. to Dr. Chen for the translation. It's a very hard word. Thank you very much. You must translate the acronym. Thank you. Should we take questions or after that? After the second test session, we'll have some questions again, okay? Yes. Yeah. It's too intense. Yeah. Don't be too intense, okay?
số ở mấy cái tài sản quá.
Cho chị xin thêm một trang cái. Tưởng là nó cái củ nó ở lòng tay này.
Dạ chứ.
Giống như một cái củ.
cái xíu cái đây rồi tắt thì sao đi luôn tắt cái dẹp rồi dẹp qua chai với tắt cabin anh đang quay cabin quá
cãi nổi đâu bao nhiêu đứa mình đi làm rồi còn khám tôi mình chỉ mình biết của im trời nghe thôi không phải đến được gì mà ông bay cũng phải biên bản nó phạt bao nhiêu thì không biết. Nước thì bọt vào là phạt một phía kia thì nó cất, xong một hồi sau nó thấy cả đám thì phạt, nó không có gì xảy ra hết. Cô là con mình. Thường đó là cô bán nước, ví dụ như cô bán trà tắc, cà phê, này kia không có. Cô biết là như có một cái đứa việc bán trong một khoa, cô lấy nước rồi hay uống, cà phê, không mấy chị em đó rồi. Biết là đi ra đi vô mà thấy có xe lạ cái gì không gì lớn không phải.
Mọi người chuẩn bị bài để cho mình tiếp tục cái phần 2 của cái bài báo cáo hôm nay. Mình lưu ý là mình không có quay phim chụp hình. Không có phim chụp hình. Với lại khi mình nghe mình nói chuyện á, mình lấy cái gì ra, không nói chuyện ra, can mai này mình nói chuyện á, mình nói với nhau nghe rất là ồn. Khi mà mình đang mình nói chuyện là nó rất là ồn, mọi người lưu ý. Mọi người ơi, mình vô để chuẩn bị cái phần 2.
Okay, we have to start, otherwise time is really quite constrained. So the second topic is quite contrary to the first one. First one, that's the class 2, but we never call it class 2 or 3 because it's not accurate. Okay. Now the second part will be more intense. It's about class 3 or the malfunction with facial concavity. Okay. We mentioned about S8, now it's all about S10 and S16, okay? Take a look. First of all, we have a classification. We have to understand classification first, otherwise it will be very hard. Now, angles classification is a traditional, it's not accurate. Okay, angle looking to molar relationship as a thing, like structure,